Good morning, everybody. We're going to talk about perioperative issues in heart failure, cardiomyopathies. If you've heard me give a similar talk, I've changed it this year somewhat significantly. About 2/3 is stay focused at the physiology aspect to make sure you understand the background and the basal physiologic and pathophysiologic issues. And then about 1/3 is related to medical management of these patients in the perioperative period. I don't have anything to disclose. This is a case that was a real case, a 65-year-old lady who went to another hospital. She was seen there. She had an ischemic lower extremity. They put her on some heparin. Her ischemic lower extremity got worse. They didn't have invasive radiology to be able to do something about it, or a vascular surgeon, so she got transferred. She was seen, as it says here, her transfer notes say she had an EF of 20% on an echo. Her blood pressure when she got to the other hospital in the ED was 215/115. At the hospital that she was treated at, she went to the OR. Anesthesia saw the EF of 20% and decided to put in a Swan-Ganz pulmonary artery catheter. They did so. Her cardiac output was 2.0. They gave 500 of fluid. Her cardiac output was 2.0. They did the case on epinephrine. Remarkably, the surgeons were able to get the leg open despite the poor flow at that cardiac output. And she came to the ICU on an epi-drip, acidotic, lactemic, oliguric, and mottled, with the family asking, could we consider changing our goals of care, because she really didn't want surgery beforehand, and now she looked like, their phrase, death warmed over. And so we convinced them to not do that, but to wait, and we'll talk about why as we go through this. So when you hear somebody has congestive heart failure, are you thinking cardiogenic, non-cardiogenic? Are you thinking pulmonary edema, non-pulmonary edema? Are you thinking pleural effusions? What happens if they have effusions and pulmonary edema? Are those different patients or not? Do we get these confused sometimes? Maybe they had acute renal failure relative to drug use and got into pulmonary edema state. Do we now, somebody wrote in the chart heart failure, so now we dutifully for the next 50 years write heart failure in the chart. And when our brain hears heart failure, what we think about is a pump that's failed. And if the pump has failed, then we think about the inability to push blood forward. So blood backs up, that backs up in the lungs, we get pulmonary edema. So we think about patients that have heart failure, natively our brain goes to reduced cardiac function. And as I think most people are aware, that's not true anymore. And we'll cover that in just a second. I just wanted to point out there's a lot of causes of heart failure. They're on 2 slides worth. We're not going to do that. What we're going to do is we're going to focus at lumping them together into 2 physiologic states, what we used to call diastolic or systolic dysfunction, what we now think of as reduced or preserved function. And again, I'll cover more as we go forward. Some people think they can predict who has heart failure in the perioperative period. They took vascular patients in this study to the OR. They had cath them first. It turned out that the most predictive variable for perioperative pulmonary edema was diastolic dysfunction, not systolic dysfunction, as the providers had proposed, hypothesized before doing the study. And the most common complication listed in the charts was congestive heart failure, whether that was auscultation or X-ray or CT or whatever, it didn't matter. That's what the most common complication was. And the diastolic dysfunction was more predictive than the systolic. Again, the providers had predicted the systolic would be more predictive. So we now know we call these patients by this set of letters, HFrEF and HFpEF, for heart failure reduced EF and heart failure preserved EF. I promised you some physiology, so let's just look at a volume pressure curve for the left side of the heart. The mitral valve opens, it fills across the bottom, diastolic filling. You then get isovolumetric contraction. This is the left side, so the aortic valve opens. You then get ejection across the top, and then you get isovolumetric relaxation, and then the next beat of the heart goes again. As a reminder, the total volume left at end diastole after it fills is the end diastolic volume, and it's measured by that line on the volume pressure graph. What's left after ejection is the end systolic volume, and it's what's left, so it's that. And the difference between those is the stroke volume that was ejected. Remember that EDV minus ESV is stroke volume, and that EF is stroke volume times EDV. So it's what you pushed out over where you started, okay? And your organs care about what your flow is and what your perfusion pressure is. They don't care what your EF is. EF is an artificially constructed terminology that we use to understand echo findings, and people misinterpret them frequently. So that's what these few points on these few slides here in the middle are about. We want to make sure that you remember what EF is versus what these other variables are. To do that, I'm going to reinforce that by just saying, say you had a 75-year-old man and he has an EF of 15%, and so you decide to do his case with a pulmonary artery catheter and you place it and you get a cardiac output of 7 liters. Is that possible? And most people would answer yes. They would say that cardiac output is stroke volume times heart rate, so if the heart rate is faster, then you could maintain cardiac output and you could actually elevate cardiac output. Turns out mathematically that's correct, but physiologically there's a problem. The problem is what? Is that the faster your heart rate, the shorter the time you have for filling. And so if you have shorter time for filling, you compromise stroke volume. And so math can't show us well that that cardiac output is dependent upon both variables being normal. And so the EF is, again, stroke volume divided by that end diastolic volume. So I want you to keep in mind that they're similar. They both have stroke volume in them, but they're different. EF is not a bad way of thinking about the overall function, but it does not really tell you what the organs are seeing. That's really more about flow and perfusion pressure. We'll talk some more about that. So the answer to this question is that a 50% ejection of a small ventricle is the same volume as a 30% ejection of a large ventricle, and so you end up with the same stroke volume, but at different EFs. So let's think about where this curve that we looked at a few minutes ago would be if you had a hypertrophied ventricle, a preserved function ventricle, and the answer is up and to the left. It's not just up, it's not just that the pressure's higher, and it's not just to the left that you can get more volume in. It's that as you try to get volume in, the pressure is escalating quickly. It's up and to the left, okay? So again, people decided, let's go to the cath lab with a group of patients. Let's see if we can learn from that information. And lo and behold, look at this. If you had end diastolic volume problems, if you had diastolic dysfunction, if you had preserved function, heart failure, then your end diastolic volume was lower, right? As we just showed that it would be. The curve is to the left, the volume is lower. But notice the pressure gradient caused by that lower volume is actually higher, 3 times higher than, so your risk of flash pulmonary edema is higher in the patients, despite the fact that they have smaller volumes of fluid within their cardiovascular space. So I do this not to make fun of these gentlemen, but to sort of give you a visual idea of what we're talking about. We're talking about muscles, in our case cardiac, in their case maybe non-cardiac, that are hypertrophied and have difficulty relaxation, okay? So that's what's going on in diastolic dysfunction. You're trying to get fluid into a tight vessel, and so the pressure goes escalated as the fluid comes in, and you get risk of flash pulmonary edema. So the patient's asymptomatic progressively through their life, and then suddenly has some event that occurs and causes flash pulmonary edema. That's the common scenario in the preserved function patients. Lots of ways to diagnose it. The more common have gotten into echo. Lots of phrases you might see on echo report. I list them there that have implications relative to diastolic dysfunction. The 2 at the bottom are the more common ones being used today, but to be complete, these are the variables released by the American Society of Echocardiography and the European Association of Cardiovascular Imaging, and these are the echo findings that are consistent with diastolic dysfunction. The most common one is the E to E prime ratio of greater than 14. You saw that at the bottom of the last slide. You should know that there's a lot of work ongoing to develop new and better strategies. The present approach, I'm not going to go into the details about it, are looking at evaluation and utilization of what's called global longitudinal strain and using speckle tracking, being able to see speckles on that image and then be able to measure things relative to the movement of those speckles and being able to then determine whether the patient has diastolic dysfunction, relaxation problems. You could see, as I mentioned on a previous slide, a couple of slides ago, that they may have an E to A reversal. I just want to remind you what that is. So in the normal heart, lots of blood leaves the atria into the ventricle when the valve opens. It passively flows. It has a higher Doppler signal. There's less blood left. The atria contracts and it tops off the ventricle, so you get a smaller peak called the A peak. When the ventricle's stiff and the valve opens, then not as much blood can rush through, so the E value falls. There's more blood left, so when it contracts, there's a higher pressure associated with that because of the stiff ventricle you're trying to move the blood into, and so you get this E to A pattern that reverses in terms of the Doppler signal. You could do echo and color Doppler echo and look at the slope of filling, and you would see that there are differences. What it comes down to is we have a variety of illnesses that can produce similar sorts of issues relative to diastolic dysfunction. I've named just several of them here for you. Now, when you're thinking about managing these patients, since I promised you we would talk about that aspect, I just want to set the stage, again, with a little physiology sort of, and say, I made up the normal numbers just to be sort of normal, to be something that makes math easy and to make the comparison easy. When you have diastolic dysfunction, remember it's to the left, so your end diastolic volume is lower, your end systolic volume is lower, you're already ejecting almost everything you can. You have very little left, okay? So you see the stroke volumes are the same between the normal and that person. They have the same cardiac outputs, but two completely different EFs and two different pressure responses to that volume, meaning two different risks of flash pulmonary edema. So what happens if you run that person dry that has diastolic? They're already squeezing almost everything out of their heart. They can't accelerate anymore. They can't squeeze any more out. There's nothing to give anymore. And so you're going to run hypotension potentially and or organ malperfusion associated with it. So you have to stay relatively euvolemic. And you'll see what we talk about in terms of the reduced function in just a couple of minutes. So can we use this sort of grid to think about how to manage these patients? The answer is yes. If you have diastolic dysfunction, you remember if they're fast, then you compromise filling. So what you want is a normal to slower heart rate. You want the volume to be relatively euvolemic. You don't want to run them bone dry. That's a problem. They won't tolerate that. And afterload management is important in diastolic dysfunction for chronically reducing the pressure gradient that is adding to the hypertrophy of the ventricle. But in an acute sense, those guys are happy if you put more weight on. You want to give me more resistance, I'll deal with more resistance. So it's not really an acute strategy as much of a chronic strategy, afterload management. So don't run them bone dry. Inotropes would worsen the problem. They already are tight. They already are stiff as a ventricle. If you start kicking it to try to get it to contract more, that's going to be problematic. They do better with drugs like beta blockers and calcium channel blockers that give a lusitropic, a relaxation response to these medications. If we jump to the reduced ejection fraction group, or historically called systolic dysfunction, we see big ventricles, we see it on chest x-ray. The same physiologic issue is where does the curve go? In this case, the volumes are bigger because the heart is dilated, so it's up and to the right. So the volumes are bigger, but at the compromise again of pressure associated with that. Same sort of question, what can you use? It's important overall, but the most common in today's world is echo. Mentioning the more common differential for you and getting us back to the same comparison table. If the curve is to the right and up, then the volumes are bigger, but the pressures are the same. So notice the three stroke volumes are the same. So the cardiac output at a given heart rate would be identical between all three groups of patients, despite having a poor EF, a normal EF, or a robust EF. Okay, so I want you to walk away with that clearly in your mind today. How about, can we use the physiologic components to think about treatment? And that answer is yes. So because we lumped in aortic insufficiency, we need to be careful about about high heart rates. I'm sorry, we need to be careful about low heart rates, and they tend to tolerate slightly more high heart rates. And we need to think about reducing their afterload because they have difficulty squeezing. And so if you increase the resistance, the ventricle fails even more. Or if you make the pressure gradient worse, the ventricle fails even more, something we see very commonly with volume overload and failure of the right ventricle as an example. You can assess your patient who has heart failure. You can talk about their stages from pre-heart failure to advanced, A through D. You can talk about their classes, which is asymptomatic, and then 3 levels of symptomatic at moderate, symptomatic at mild, and symptomatic at rest. You can think about how it connects with all their comorbidities as well. But in the end, you want to remember that again, they've already squeezing out everything they can. If you compromise their volume too much, then they're going to get into trouble. So you have to maintain relative euvolemia again. This group is going to like getting some inotropic help, and vasodilators can be quite useful as well. But you have to remember that some of these patients are walking around at blood pressures that are much lower than what we consider standard blood pressures because they've been acutely managed for their heart failure for some time. And that's a good thing, but the problem is we then get worried because they show up at a blood pressure systolic of 85 or 90. That may be what they normally run, so it can make us quite nervous. There are clinical types or clinical phases that you need to think about because they can help you interact with where the patient is with the procedure that's about to happen. So I'm trying to show you the first patient on this list, the top clinical phase, right? Their blood pressure is relatively normal, their heart rate is relatively normal, and their exam also shows well perfused. So this patient's going to do very differently in a low volume blood loss case and a high volume blood loss case than the person at the bottom of the list who's got already walking around at compromised blood pressure, so compromised flow. They're already using heart rate at baseline to try to maintain cardiac output, to try to maintain that pressure and flow, and they have an exam that is consistent with being very uncompensated. So you're going to see something very different, and how you have to think about monitoring the patient is going to be different based upon which of those phases the patient might be in. I just wanted to sort of summarize all of that into a simple table for you to think about what are the management strategies, and then I'm going to talk a little bit more about that as we wrap up here shortly. So you have a group of patients who they've not been previously treated for heart failure, and you end up making the diagnosis in the perioperative period. Variety of reasons you may, but you do. And so you need to remember, what do you do? And people say, well, you're going to start medications, particularly beta blockers and ACE inhibitors. You're going to start low and you're going to go slow. So these are chronic management for these patients. It's okay if you wait an extra day before you start in most patients. Don't feel like you have to rush and crash onto these. Some people would suggest that maybe ACE inhibitors, you start before the beta blockers in this group. That's a new start. Many of these patients might get there and have all sorts of problems, including perioperative cardiac events. So you may end up starting with the beta blocker. Again, it doesn't matter. Start low, stay low, go slow. And remember that if they can't take PO, there are IV forms, but typically what happens if you're having to think about an IV form, unless they've had compromise and resection of their bowel, so they're not going to absorb oral agents, then you're probably starting the drug too soon if you're that worried about them being nervous about how they're going to tolerate the medication. And then you go up on it, but you go up very slow. Most people tend to alternate. They go up on the beta blocker this visit. They see the patient several weeks or months later. They go up on the ACE inhibitor at the next visit, and they sort of titrate slowly because, again, these are chronic long-term management. How about the patient who was on it already, had one of these disorders, is already on them? Well, most people would suggest you try to get them back on the beta blocker as fast as you can because they are used to being beta blocked, and they're now in a hyperadrenergic state. If their heart rate is low, then that may force you to consider starting on the ACE inhibitors. And again, you're going to end up wanting to be on both. So don't fret it too much if you can't start the beta blocker and their heart rate is already controlled. The question comes up frequently, do I give them carvedilol or can I use metoprolol? Well, carvedilol is only oral. The data is about this, that they're about equivalent. Maybe you could make an argument that carvedilol is a smidge better, but if you can't give carvedilol, then it's fine to give metoprolol. You may have to start very low, 1 milligram IV Q6, 2 milligrams IV Q6, something very, very small. If they have HFpEF, they tend to be hypertensive at baseline. They may now be in the postoperative period and be very hypertensive. You may be starting these meds and not getting blood pressure down. So you may have to think about going faster with your titration because they can tolerate it a little bit more. But if the blood pressure is resistant, then you have to think about giving a mineralocorticoid antagonist like spironolactone. Or you have to think about giving one of what are called the ARNIs or ARNIs. It's the angiotensin receptor and the prisoline inhibitor. So these are like secubutrol and valsartan mixed together as an agent. These work because they prevent the breakdown of natriuretic peptide, and so you get more fluid removal off of the patient because of that breakdown of the blockage of the breakdown. I want to remind you that if you have a patient in the perioperative period, don't forget, just because they have a history of either HFpEF or HFrEF doesn't mean they don't have a new cause in the perioperative period of a different type of heart failure that's associated with stress cardiomyopathy, a Takotsubo. And so remember, you've got to think about echoing your patients early. You might have to repeat echo just because they had one a week ago doesn't mean if they're still under stress and they're having a problem, maybe a new disorder has come on board. So you may have to think about POCUS or a formal echo and redoing it. I need to wrap up as we have just a few minutes left. So let me take us back to this is the identical wording of the case that we saw at the beginning of this. Is it possible that you could have a blood pressure of 215 over 115 with an ejection fraction of 15% or 20%? The answer is no, right? It's very common that we would put a blood pressure cuff on and measure a blood pressure and measure something lower than the patient really is. So one of those must be wrong. If the EF is really poor and they can't squeeze, then they're unlikely to get high pressure, right? And if they're unlikely to get high pressure, they're not going to get this. In fact, if their resistance were driving this blood pressure, the heart would fail even more. We talked about that. So this is very doubtful. So one must be true. And it's more likely it's the blood pressure that's true in this scenario than the EF. And so we could not get a copy of the echo from the other hospital. We only had the discharge summary, which said it was 20%. We didn't have an echo report showing that it was 20%. Turns out that was a mistake, and we got this one right. And we gave the person fluid, significant volumes, was able to wean the patient off of the epinephrine. The family then was very happy when they came in the morning and the patient was sitting in a chair and having breakfast, and they hadn't changed the goals of care. We had better identified what was really going on in the patient. So I'm going to remind you that congestive heart failure is a grab bag of issues. It needs to be clarified. I will hope that you will stop the train of just writing heart failure in the chart if somebody else wrote it, but spend a little bit of effort trying to understand, is it symptomatic or asymptomatic? Is it HFpEF or is it HFrEF? I hope I've convinced you that the outcomes are different, that the strategies of treatment are important and are not the same, whether those be acute management or chronic management. And so that having a clear understanding of these differences will help you provide better care to your patient and patient's family. Thank you very much.